So let's see BRCA1, BRCA2 mutations in ovarian cancer as a short note for 15 marks. Why don't we start with a flow chart instead of definitions? So BRCA1, BRCA2 genetic mutation. So what does it cause? Next, defective homologous recombination repair. Next, double-stranded DNA breaks that cannot be repaired. So this leads to the genomic instability, and that further causes high-grade ovarian cancers. This is the basic thing. And it is also known that when this is happening, the next thing that we clinically relate to is increased platinum sensitivity, increased PARP inhibitor sensitivity. That leads to further improved survival and a personalized treatment option which is available for BRCA and BRCA2 mutated ovarian cancers. Basically, definition: BRCA1, BRCA2. BRCA1 is in 17q21. BRCA2 is in 13q12. They are tumor suppressor genes which are involved in homologous recombination repair of DNA. The mutation of this results in genomic instability and defective DNA repair. It is one of the most clinically important predictive biomarker in epithelial ovarian cancers because they determine, you put 4 arrows, each arrow, prognosis, it determines the prognosis, platinum sensitivity, eligibility for PARP inhibitor, genetic and family counseling, and in some cases a 5th arrow to say that it can help guide risk reducing surgeries. So these are the predictive biomarkers and its importance. Before that we wrote the definition, before that we put a flow chart. If you see BRCA1, BRCA2 accounts for 90% of the hereditary ovarian cancers. So, and this lifetime risk of ovarian cancer is 40% with BRCA1 and close to 20% with BRCA2. Something that we need to remember. Usually they are high-grade serous and have better platinum sensitivity. We can put this BRCA1, BRCA2 difference as a small tabular column also. So we write homologous recombination repair. Normal cell, what happens is there is a DNA break, BRCA1 gets recruited, DNA end is resected, BRCA2 loads the RAD51 and accurate homologous recombination occurs and DNA is repaired, ligated, and it is done perfectly. Say BRCA is mutated, we have the damaged DNA. There is no functional BRCA, so what happens? So there is no homologous recombination repair, error prone repair, no homologous end joining repair can happen. Mutations will start to accumulate and that leads to carcinogenesis. The BRCA protein acts as a scaffold gene or a protein that coordinates this HRR. But now that entire pathway is. We write a word about synthetic lethality. It is with respect to PARP inhibitors. What happens is, PARP is the enzyme that actually repairs a single-stranded DNA break in the normal pathway. When BRCA is mutated and we give PARP inhibitor, what happens is PARP is going to block this repair mechanism. Single-stranded break starts to accumulate and they will become double-stranded breaks. So in normal cells, this will get repaired. Cells will survive. But in BRCA mutated cells, this damage which is caused by PARP inhibition is also additionally not being repaired, which leads to catastrophic DNA damage and tumor cell death. Say this is happening inside the tumor cells start to die. So there is already BRCA mutation. On top of that, synthetic lethality is something where we add PARP inhibition and all that leads to DNA repair defect and cell death, cancer cell death. So that is something that we need to write. Clinically, it is important in hereditary breast ovarian cancer syndromes, Lynch syndrome, and pathologically BRCA1, BRCA2 mutated cancer, high-grade serous, tubal in origin, have p53 mutation and HRD positive. So testing recommendations. I was reading the TMH textbook. And we usually recommend all patients with ovarian cancers and peritoneal carcinoma should undergo germline BRCA testing irrespective of age and family history. Say if germline testing is negative, tumor testing for somatic BRCA and HRD should be considered so that we can decide on PARP inhibition. So this is something that we learn, and clinical significance we write about this, and then maybe we can also write about maintenance treatment with olaparib in case of PARP inhibition. Olaparib is the most common PARP inhibitor, BRCA mutation, first line in maintenance. Regardless of BRCA status, sometimes niraparib can be used, but it is most effective in HRD positive patients. Germline somatic BRCA recurrent disease, you can use rucaparib. 3 PARP inhibitors, drug can be mentioned. The landmark trial for use of olaparib 300 mg BD for 2 years as maintenance was established as first line after this trial, Solo 1. Newly diagnosed figure 1, figure 2, complete or partial response after platinum chemotherapy. There was a median progression-free survival benefit. Significant, almost more than 35 months improvement if we give maintenance olaparib for 2 years. Then we had one more trial where olaparib plus bevacizumab was used. This combination for HRD positive was even better. Advanced ovarian cancers. This was based on the Paola trial. Then niraparib versus placebo, and niraparib showed benefit in progression-free survival in HRD positive ovarian cancer patients after response to platinum in advanced ovarian cancer by the Prima trial. So Solo 1, Paola and Prima. Prima was specifically for niraparib. Paola was for olaparib plus bev. Solo 1 was for olaparib 300 mg. And Solo 2 is also there. I think Solo 2 was again for olaparib maintenance until progression after recurrence. The recurrence setting, platinum sensitive recurrent. We write the common toxicities with PARP inhibitors, maybe anemia, thrombocytopenia, neutropenia, AML, MDS is also there. Anemia is something that is important. Risk reducing strategies in BRCA carriers. Clinical examination, genetic counseling, breast cancer screening. After completion of childbearing, BRCA 1, 35 to 40 years, they can undergo risk reducing bilateral salving oophorectomy. In BRCA 2, 40 to 45 years age group, they can go. Okay. Family counseling, we will have to write about testing first degree relatives, second degree relatives, if any significant history is present, and discuss to them regarding breast cancer, ovarian cancer, risk fertility issues. Yeah, BRCA 1, BRCA 2 and ovarian cancer, all this is what we should discuss.